Hey guys, I'm here with Adam Meakins. Adam's a physio. He's involved in research and a pretty prominent figure online combating misinformation in the fitness and health world. So I just want to have a chat with him today about some controversial topics. Adam, if you're happy, would you mind just giving a brief introduction of yourself, both personally and professionally?
Yeah, sure. I'm not sure if it's going to be brief, but I'll be try. It's one thing I'm not known for is being brief, but I'll give it a go. Hi everybody. My name is Adam. I am a physiotherapist and have been for 22 years now. Haven't always been a physiotherapist though. So my background originally, when I was a very, very young man, I left school, went into the military for a few years, did a bit of service with the British Army, left the military, came out onto civilian street, not knowing what to do with myself. So I went and did a degree in sports science first, which gave me the glorified title of a sports scientist, which is a degree that I really didn't know how to use. So I became a personal trainer, a strength and conditioning coach, because they taught me a lot about exercise, physiology, and all that sort of stuff. So I started working, as I say, as a trainer and a coach, which I enjoyed for a couple of years, but then I started coming across people with injuries, and that's what led me into finally doing my second degree in physiotherapy back in the late 90s. And then qualified as a physiotherapist and very quickly became disillusioned with the profession because I found it full of a lot of bullshit and nonsense and lots of claims of superiority and specificness of how we can help people with injuries. And I just felt I was wasting my time doing all this stupid poking and pressing and rubbing people and it not actually making any difference. And there was very little training or promotion on health, on education, on exercise, which I thought was the much more important stuff that we should be doing to help people with their pains and disabilities. So, as you said, over the last 10 years or so, I have now made a bit of a name for myself as being this individual on social media who goes around questioning and challenging a lot of the silly bullshit that physiotherapy and a lot of other therapists promote out there. And I don't blame them for promoting it because it's what they get taught to promote. It's what they get taught to believe. And it just seems to be a vicious circle that I think somebody's got to try and break. So me and a few others now are trying to challenge the dogma and try to get therapists focusing on things that I say are a bit more important for people with pain and injury, not the rubbing and the poking and the pressing and the stabbing and the sticking and the scraping and the cupping and all that sort of nonsense, but getting people focused on movement-based strategies, exercise, health, lifestyle, all that sort of stuff, which is where I think the magic lies. So that's me in a not so small nutshell, mate.
That's great. And your work's definitely appreciated. At least I personally appreciate it. So thanks for all you do. One thing that's very big on social media right now is bulletproofing routines. So here's a routine to bulletproof your back, bulletproof your knees. I think hot topics right now are things like tib ant raises and VMO squats, if you can even call them that. These are very appealing to the general public. It makes sense to want to avoid injury. However, I think people put a little bit too much faith in them and think that they can really, bulletproof something or make a joint so resilient that you will be immune to injury. Would you mind just talking a little bit about the multifactorial nature of injury and whether or not you think these can be a panacea for injury prevention?
Yeah, of course. And I agree. I do see these things becoming more and more popular on social media with routines being sold to, as you say, bulletproof or protect yourself against injury. And the simple answer is I wish it was that simple because it would make my life so much easier. If we could just suddenly magically make all injuries disappear by doing a routine of exercises, then I think all of healthcare would be immensely grateful for it because it means that there'll be a lot of work there taken off them. And then there'll be other things that they could focus their time and energy and effort on because all healthcare professionals are incredibly busy people, overloaded people because of the amount of people needing help and the support and assistance. So if we could eradicate back pain by getting people to do these bulletproofing exercise routines, that would be great. But it just isn't that simple. Exercise alone is not protective against pain or injury, but it's better than not doing exercise. So, I still think these things can help people, but just probably not in the way that they think. Doing some exercises can actually, does help. We know the evidence supports this, reduce your risk of getting disease and pathology, and therefore pains and problems as well. So I'll certainly say, you know, doing these routines is better than sitting on the sofa doing nothing. But I don't want people to think that it is, you know, magically just going to make your risk of injury disappear or go to completely zero, because that's just not true at all. And I think, you know, what we've got to try and do is get people that are exercising prepared and ready for injury. I say to people, you know, if you are exercising routinely and regularly, be prepared to have injuries now and again, because that's been part of a human being. That's natural. We've got to normalize pain and injury rather than demonizing it, rather than making it seem to be this scary thing that should never happen. It's going to happen. It's how you are prepared to deal with it when it does happen. Are you psychologically ready? Are you prepared to have a bit of frustration? Are you prepared to have a bit of time off and focusing on other things as well? So, you know, that's how I like to try and bulletproof people against injury. It's more about getting them prepared for it when it occurs. It's not actually about preventing it, because it's just impossible to do.
Yeah, fully agreed. So I think some other things like the choice of your physical activity is a huge influence on your injury risk. So doing something like MMA is going to be a lot more dangerous than, you know, going for brisk walks every now and then. And I don't think there's any amount of strength, mobility, and neuromuscular control that can make you immune to injury in an open sport such as basketball, football, jiu-jitsu. So while bulletproofing probably helps, I think honestly choosing a different type of physical activities probably can probably have a larger effect than just getting strong.
Absolutely. And I think, you know, when you look again into the evidence, into the research base at the injury prevalence figures, it always surprises people about what type of sports have higher injury prevalence and which types of activities or sports have lower injury prevalence. The classic one is strength training, powerlifting, Olympic lifting. Everybody thinks that's a high risk type of sport to do. Oh, you're picking up great big heavy weights, you're going to end up injuring yourself a lot. You're going to end up with all the imbalances and get all these sorts of problems. And actually, the evidence tells us that weightlifting, resistance training, strength training, powerlifting, Olympic lifting has some of the lowest incidences of injury risk out of all the types of sports and activities. Yet something like running, which people assume is nice and easy and it's simple to do and it's got very low risk of injury, has one of the highest risk of injury. So we normally categorize prevalence of injuries per 1,000 hours of exposure. So for every 1,000 hours of exposures, how many injuries are you going to get in that 1,000 hours of exposure? So for something like resistance training, powerlifting, it's between 1 and 2 injuries per 1,000. When you go into running, depending on whether you're a novice or an experienced runner, it can be anywhere between 14 and 35 injuries per 1,000 hours. So, you know, the research tells us that, as I say, we do expect injuries to occur, as you said, and it is variable based on the type of sport and the activity that you do. And some are higher risk and lower risk than others. But then again, the other key factor that I think a lot of people forget as well is their experience. Are they a novice or are they somebody who's experienced at that particular sport as well? Because that hugely changes the risk of injury rates that we see. One of my little cheesy sayings that I say to people about trying to reduce their risk of injury when running, say if you're a marathon runner, is you need to have run 10 marathons first to reduce your risk of getting injuries in marathons. So the more exposure you have with a particular type of sport, you tend to see that your injury risk lowers because your body adapts to it. It starts to become used to the stresses and the forces that the sport and the activity is exposing to you. So being experienced in something is definitely a key way, a strategy of reducing your injury risk.
Even within very similar sports such as powerlifting versus Olympic weightlifting versus bodybuilding, where they're all lifting weights, I think you do see small differences in injury rates. The way you perform your weightlifting can influence your risk of injury. It makes perfect sense. You know, powerlifting is very heavy loads. Weightlifting is quite a dynamic activity close to your limit, whereas bodybuilding tends to be slow and controlled and higher rep ranges. It makes sense that you would see few injuries there. One other thing
Absolutely.
I want to point out as well to listeners is that a lot of your risk of injury comes down to, did you pick the right parents? And unfortunately, you can't really do anything about that. So you can do all the bulletproofing routines you want, but if you kind of are genetically predisposed to a certain type of injury, yeah, no bulletproofing routine is going to save you.
Yeah, that's a great point. Genetics is a key factor. You know, I was looking a lot into that recently with disc herniations and disc prolapses. And again, we've seen a number of studies done on genetically identical twins showing, you know, they have various different life exposures, they have various different environmental factors acting on their bodies, but they have very similar looking discs. So again, it shows that somebody that's doing one type of sport that's considered to be risky for a disc injury, if they're identical, genetically identical twins doing another type of sport that's so-called better for their discs or less risky for their discs, we don't see any significant difference in their disc adaptations or imaging later on in life. So we do know genetics is a key factor for how your body responds to certain different stimuluses and loads, etc. So yeah, it's a great point. As you say, your genetics are probably the thing that a lot of people overlook or don't understand. The other thing with genetics as well is we have this thing called epigenetics, where, you know, your genetics can be hugely influenced based on environmental factors as well. So, you know, although, you know, a lot of people talk of genetics, I don't want people thinking they're out of their control. There's nothing you can do about them, because the environment that your genes are exposed to hugely dictates whether they are going to be a problem or a benefit for you as well.
Yep, absolutely. So do you think on average, I'm just going to go out on a limb here and say, I don't think these bulletproofing routines on average would have any better effect than a general strengthening routine with a bit of neuromuscular control work. Would you agree with that? Or do you think?
Absolutely. You know, trying to find the holy grail of one type of routine or one type of exercise being superior or better than any other type is something I've been searching for at least 10 years, probably even longer than that. And I've been, you know, misled a lot of the times into thinking a certain particular type of exercise, contraction type, loading parameter, frequency parameter was the golden nugget, was the more superior approach to help people with pain and pathology and injury and disease. And the simple answer is there is no superiority of any one particular type of exercise. The only thing that's superior is the exercise itself.
Yep.
You know, we see superiority of people that engage with the exercise. It doesn't really matter what type of exercise it is.
Absolutely, yeah. So something like, I think strength training definitely reduces your risk of injury, but if you want to do squats or you want to do leg press or deadlifts or pistols, lunges, do what you like, get stronger. And that's a great way to reduce your risk of injury there. In calisthenics, a lot of people, and in fitness in general, a lot of people talk about this idea of structural balance. And there was an article written by Charles Poliquin a long time ago with numbers that you should aim for and ratios that you should aim for. What do you think about structural balance and the recommendations that you should balance vertical pushing with vertical pulling, horizontal pushing with horizontal pulling, or have some sort of ratio there?
Yeah, again, these things I've come across them a number of times as well throughout my career and training as well, with people recommending, you know, push-pull ratios of 1-2 or 1-3 or whatever it is. And I think, you know, they're people's opinions, and they're not really backed up by a lot of hard empirical evidence. So, you know, there's nothing to really support them with hard and fast facts or data. Excuse me. That they reduce the risk again of injury, or they help improve performance. So that's what they're normally often promoted as doing. Reduce again your risk of injury, or they'll promote and benefit your performance by keeping things, as say, working better. But there just is no hard and fast proof of that. But again, I do think it comes down to the individual and the type of sport they're doing. You know, if somebody is doing something at high volumes, at high frequency, at high intensity, the same bloody way all the time, I think that does start to reduce their variety of loads and stimuluses on their body. And therefore, getting them to do something different, opposite, if you want to say, you know, can help give them a period of time of exposing their tissues to a different stimulus. But I don't think it's got to be on this, you know, ideal ratio base. But I do think some individuals do definitely have some benefit from focusing on doing things in the opposite way or a different way than what they are routinely doing. So if you are in a sport or a hobby that is very much push dominant or quadricep dominant or internal rotation dominant, so let's say you're a thrower or you're a bench presser or you are, you know, a jumper, you know, where you're jumping up and down a lot of the time, then yes, doing some other exercises that work the muscles in the opposite direction occasionally at a certain time will help your body withstand, and I think have different stimuluses and withstand their loads and stresses that you apply to it on a regular basis. But I don't think, again, it needs to be on any specific ratio. I think that's just a bit, as I say, opinion rather than any data.
I fully agree with that. My general recommendation is it's probably a good idea to train both sides of a joint and a variety of movements. However, that's about as strict as my recommendation is. And I can understand why people, find these internet gurus appealing, because there's a sense of certainty there. If, I feel that the recommendations that we've given aren't very satisfying to the general public. But I think they're well thought out, and I think they're the best understanding of the data we've got at the moment. Whereas if I said, hey, Adam, you have to do 3 sets of horizontal pulling to every set of vertical pushing, it sounds like it's based on something, but generally it's not. And generally the people with that talk with that much certainty are making things up.
Yeah, no, I agree. Yes, certainty gives the illusion of control in uncertain environments, and I think some people master that really, really well. And sometimes that can be a positive, but also sometimes that can be a negative as well. But yeah, we've just got to realize that there is a lot of uncertainty in life in general. I love cosmology. I love the fact that some of the smartest physicians in the world, physicists in the world, still don't know 95% of the universe. We've got so many uncertainties about how atoms are working, and what dark energy is, and what's going on with around black holes, and all this uncertainty around things that we were first led to believe was very clear cut, was very certain, and now we know that 95% of the universe is unexplained. So that gives me some relief that the fact that in the industry and the profession that I work in also has a shitload of uncertainty. We are uncertain about why things work and why things don't work, why some people get injured and why some people don't get injured. We've got a lot of uncertainty about what's the best type of things to be doing. So I just think, us as humans, we don't like uncertainty, but we've got to get better at dealing with it, at better at accepting it. But as you say, it's tricky to do, and certainty does sell. It's almost as sexy as sex. Sex sells, and uncertainty sells as well.
Agreed. And I see a lot of parallels with it, in the nutrition field. I think if you speak to the experts, they often say there are many ways to have a healthy diet, and we can't say that eating broccoli is better than eating some other vegetable. However, you have people promoting vegan diets are the healthiest diets. You have people on the other spectrum promoting carnivore diets as being the healthiest diets with absolute certainty. And I think the expert opinion is a lot less uncertain, a lot more vague. And unfortunately, that's not as appealing to human psychology.
No, you're right there. And that's one field I try to definitely stay away from, is the nutrition world. I thought, there's a lot of teeth and nails flying around in the strength and conditioning and the fitness world, but the nutrition world's another level. So I dipped my toe in it a little bit, and I assume very much, whoa, that's another whole kettle of fish that I'm not getting involved in. But yeah, I agree.
Yeah. So on this topic of uncertainty, we talk a little bit about VMO for knee pain. So one thing that was a very hot topic when I went through university was VMO is going to solve all of your knee pain. I think you still hear a lot of that. So can we talk a little bit about VMO, whether you think there is a perfect VMO-VL ratio, and even if there is, can you do anything about that?
Yeah, again, another good question. And like yourself, Simon, I was very much the same when my training as a physiotherapist was told that misfiring or delayed firing of the VMO or weakness of the VMO caused a lot of knee problems. The mal-tracking patella, that patella being laterally deviated in the trochlear groove, and therefore that was causing excessive compression and friction on that side of the knee joint, irritating structures there. So if you start to strengthen the VM or ask it to work at a better timing or get it stronger, then it will help readdress the balance of the position of the patella and help reduce an individual's knee pain. And so, there have been some studies that try to look into that, whether, training the VMO does help improve or reduce people's knee pain. And yes, some studies show that it does, but what they didn't look into was, does it train the VMO specifically? the exercises they were giving very much were thought and led to believe be specifically targeting the VMO muscle fibers. But when you look at the anatomy of the VMO, you find that it's a unit within a foreorder muscle. It's in part of the knee extensor complex, the quadricep complex. And the belief of being able to, internally rotate the tibia or the femur or adduct the femur a bit to try and preferentiate the VMO fibers is just not being conclusively proven. So there doesn't seem to be a way to specifically target the VM over the VL or over the rectus femoris or any other part of the quadricep muscles. You're working them as a unit. And I see the same sort of discussions around the VM as I do between people talking about the upper and lower abdominal muscles, about different types of exercises targeting the upper abdominals versus the lower abdominals. The rectus abdominis muscle group is a group. You do an exercise and they contract as a unit. You can't specifically work the lower portions of the rectus abdominis more than the upper portions of the rectus abdominis. So, your knee raises are not working the lower abdominals and your crunches are not working the upper rectus abdominis muscles. But again, lots of myths and misconceptions around that. That's what they are thought to do. And it's exactly the same with the VM, squeezing a ball between your knees, turning your toes outwards to get your VM fibers on top of the knee as you're doing your knee extensors will work them more than the other parts. And it just doesn't. But the exercises that they give for these VM exercises are quadricep strengthening exercises. And therefore, they get the quadriceps as a unit stronger, which then helps people's with their knee pain. So again, we've got quite robust evidence that getting the quad capacity up, getting the quad strength up, helps people with knee problems quite a lot. So I think, again, the VM gets accredited, or these VM exercises gets accredited for helping people when actually all it's done is just get the whole quadricep muscle group working better and having more capacity. So they still work, they still help, but just not in the way that we thought or have been explained.
Yep, I fully agree with that. I think it is just getting stronger. And unfortunately, building quadricep mass and strength generally isn't as sexy as specific exercises to isolate one of the quadriceps. And just to go a bit deeper into this topic, so I think in the exercise science field, there's some evidence that you can preferentially build muscle mass in different parts of the muscle. So contracting muscles or challenging muscles at length tends to lead to slightly more hypertrophy in the distal region of a muscle, whereas contracting muscles in short positions versus long positions leads to similar growth in the proximal part of the muscle. So to me, it makes sense that maybe things like deep squats would maybe preferentially grow your VMO because your VMO is more of a distal part of your quad. However, I still don't think it actually matters. And I would never recommend that somebody only do deep squats and neglect the inner range of the quads. I think a good recommendation is just build strength generally with a variety of movements. And that's a great way your VMO will get plenty of attention there.
Yeah, I agree. I think I'm of the same mindset as well. And, my initial thoughts when you were talking about these, slight changes in proximal versus distal ends of the muscles based on the exercise range that they're doing. I think, the other thing for us to consider is, how much extra time under tension does a deep squat get versus over a quarter squat? Could it be just that extra time under tension during the exercise that creates more stimulus and therefore these slight differences that we see in the muscle units? And is there more, tempo? Is there more eccentric overload during these muscle deeper squats versus the shorter squats as well? So there's all these other variables that are often not looked at or considered as potentially why some exercises do slightly better things or different things than other types of exercises as well. It's not always just based on that sort of structural benefit that a lot of people claim it is. But as you say, specificness is sexy, it sells, it gives people that feeling of control over uncertainty again. So, it does get people to buy into them more. But at the end of the day, these exercises probably still help people. It's just not the mechanisms, it's not the explanations that are occurring that a lot of people think are occurring. And I've got no problem with people using these types of exercises as long as they're aware and they're informed that these things are not quite as clear cut as they've been told or led to believe.
Yep, I fully agree. I actually like all of the at least most of the exercises, most of the programs from people promoting VMO squats. I just wish they didn't call them VMO squats. I wish they just
Exactly
said,
right. I've seen this raise thanks to, certain social media influencers out there, this raise in deep squats, in knees over toes and all this sort of stuff. And I'm thinking, yeah, it's great. It's about bloody time, because there's been way too much of the other side of it. Don't let your knees go over toes. Keep it in perfect alignment. So yeah, I'm loving it and I'm supporting it and promoting it. As you say, it's just unfortunately they seem to have gone the other side of the coin when it comes to the explanations and the specificity about why these exercises are better or should be done. And I'm just like, no, that's no different than your other idiots that you're challenging on the other side who tell you not to put your knees over your toes. So I just wish they had that little bit more of a relaxed, or scientific explanation about, or uncertainty about what's happening when they ask people to do these exercises.
yeah, a little bit more humility in their explanation, maybe.
Yeah, that would be nice, wouldn't it?
On that topic of knees over toes, one thing I find really funny is that people who advocate not putting your knees over toes say, don't put your knees over toes because it stresses your knee. And it's like, well, exercise stresses your knee. That's why you're doing exercise, to cause stress, to cause an adaptation. It makes no sense. A lot of hypocrisy there.
It does, and it's mind-blowing when you see those explanations. I see it in the back a lot. I challenge a lot of the fact of neutral spine, and everyone's talking, flexion of the spine, it stresses the structures in your back. I'm like, it's exactly what you want. If you want a stronger back, you want your tissues to be gradually exposed to stresses to improve them, to get them stronger. So yeah, I'm with you on that. It don't make sense to me.
Let's get into back pain. So back pain is really common. I think most of us have experienced back pain at some point. If we haven't, we surely know someone who has. Can you talk about some of the risk factors for back pain? Am I getting back pain because I'm weak or because I'm unstable, Adam, or why am I getting back pain?
So the two biggest risk factors for low back pain is being a human being and having a spine. So I think, it's pretty much that's it. It's an affliction of humanity. It's something that's as common as the common cold. It's just something that, as I say, human beings have to work with and deal with, is back pain. And I don't think that a lot of human beings are dealing with it or coping with it or managing back pain very, very well. If anything, you look at the rates, we're getting worse at it, despite there being more and more treatments for back pain. So with all the advances in understanding and treatments in other areas of healthcare, we're seeing rates of, diseases and pathologies slowly reducing. But the only difference with back pain is we're seeing increases in rates and prevalence. So we are actually not doing a good thing with back pain at all. And that's because 99.9% of the time, we overdiagnose it, we overtreat it, we stress and worry people out who have got it, rather than just reassuring them. It's the common cold of musculoskeletal conditions. This is a condition that affects every human being. And just like a common cold, there's lots of reasons why you get it. Sometimes it's just you're unfortunate, you're in the wrong place at the wrong time. But there's so many different confounding variables that do contribute to somebody having an episode of low back pain. It's nigh on impossible to work out the causes of low back pain. And so I think a lot of people end up focusing way too much on that. And again, not going back to what I said earlier on, they're not just getting reassured that being injured and having an episode of pain is normal and it's okay. And I think healthcare does a very shitty job at that. I have changed my practice hugely over the years, is just compassionately and calmly listening to patients, doing a thorough assessment, doing all the things that I normally do, making sure that there's nothing serious or specific here that could be contributing to their symptoms, and then reassuring people that these things have a favorable natural history. That dirty little word that a lot of healthcare professionals don't like to talk about. Shit just gets better on its own, given time, given reassurance, and the right management and environment for the person to carry on as normal. But a lot of the time, they're not given that. They're not given the green light. They're not given the reassurance that it's okay. They're often asked to do something specific, or they're given some shitty piece of information. And that delays the natural history. That actually slows the natural history down. And then they end up getting more complications. They end up getting more problems because of it. So, when people are told you've got back pain because your pelvis is out of balance, or your spine is unstable, or your core is weak, that shit actually delays people getting back doing the things that they would normally do, because now they're focused and worried about being unstable, about having a pelvis out of alignment. And so they stop doing things that they would normally do, which would help them back to their normal recovery and follow that natural history. So again, I think with all good intentions, a lot of healthcare sometimes gives people this shitty information that actually gets in the way of natural history. And so we've got to try and do better at that. We've got to stop using these terms and these explanations. We've got to help people with back pain realize and understand it's normal, it's natural, it has a favorable natural history. If we don't get in the way of it and allow the patients to do what they would do normally, give them simple advice and guidance to keep moving, to keep exercising, because we know that helps. But it doesn't have to be specific. It doesn't have to be used to explain that they've got to do these exercises to stabilize things or address things, because that's just not true at all.
One thing you said there is it doesn't have to be specific. And one term I think a lot of people would benefit from understanding is this term of non-specific low back pain. Could you explain what that means?
Yeah, it's an unfortunate term, I think, because when you explain it to patients, or I have tried to explain it to patients, it can come across as very discompassionate. It can come across as a bit flippant and invalidating to say, you got non-specific low back pain. And I've had patients turn around to me and say, well, it's very fucking specific to me. Excuse my French. So, I think it's not a good term to actually use with people with back pain. What we mean when we're discussing non-specific no back pain as healthcare professionals is you've got no specific structural cause of back pain. We've done our assessment and we've excluded all the specific things that need specific treatment to help this episode of back pain, but they're very, very rare. We're talking things like cauda equina syndrome. We're talking about things like discitis, an infection of the disc. We're talking about a spinal fracture. These things are specific conditions that need specific management strategies, and normally not physiotherapy in the early stages. They need some form of medical intervention and treatment. So what we do with our screening process is we look for these very rare specific causes of back pain to make sure to the best of our ability that they're not there, that we haven't got the signs and symptoms of these specific causes that then needs to go on for further tests, investigations, and interventions. A lot of the time, we don't see these signs and symptoms in people with back pain, so we class them in the 95, 99 percentile of non-specific back pain. And that means there are numerous structures. There are many things that could be contributing to your back pain. It may even not be structural at all. Back pain can come across, excuse me, just like a headache can. You've had a stressy day. You've been sitting down in a period of time, placing your tissues under a certain amount of stress, and it's the final straw. And instead of getting a headache, you get a bit of a backache. And so, it can be no structural cause of it at all. So again, with that term non-specific back pain means we are unable to find one individual specific factor for the reason why you've got this back pain, which, as I said, I reckon is 95 to 99% of back pain. The only slight exception there would be radicular issues. That sort of fits in between the serious stuff. This is non-medical emergency back pain, but is a specific diagnosis. So we've got things like, disc herniations that cause nerve root impingement and compression. And they are classed under radicular issues, of which you get radicular pain, and then radiculopathy, where you get loss of sensation, loss of motor power, etc. Again, they are a specific cause of back pain, so we are able to differentiate them. But often, again, they have favorable natural histories. The good news, even with, ruptured disc herniations, they can settle down with time. It just takes longer than other causes of back pain. So they often just need, monitoring, watchful waiting, reassuring, keep moving, keep exercising, bit of pain control if you've got radicular pain, because it's fucking unpleasant, having experienced it myself a number of times. And just trying to say, wait it out and being patient with it. And that's the number one thing with back pain. It's the time. And everybody underestimates how long these things take. The natural history of things is always longer than people understand or expect or want. And I get that. And a big part, again, of healthcare is just helping people understand how long things take to get back to baseline and not underestimating it, because that stresses people out. And that often leads them to go on to seek further unnecessary treatments and interventions.
Yeah. When patients come to see physios, doctors, health professionals with back pain, it's often quite severe. And they think, if I can know what is going on with my back, my treatment will be better. Can you talk a little bit about the indications for imaging, why we don't just image everyone, and why that doesn't help and can potentially be harmful?
Yeah, sure. Well, the first reason is just the practicality of it. The sheer numbers of people that we see with back pain, there just isn't the systems or the machines or the radiographers or the radiologists in place to be able to scan everybody with back pain. So that's the first practical reason it's not done. But the more rational and simple and scientific explanation is it's just unnecessary to do a lot of the time. You know, just like you wouldn't go and get blood work done every time you have a cold, because you need to work out the specific type of virus needed to work out what's going on to give that specific virus a specific treatment. We just know we don't need to do that with back pain. So again, we know that, say, a lot of back pain has multifactorial sources, but we also know it has this natural history that within 6 to 12 weeks, most back pain is feeling better. And therefore, you know, it doesn't need to have a scan. But I get it from a patient's point of view, because it can sometimes feel like, you know, they need the answer, they need to be reassured. But we actually see the opposite side of the coin when we do that a lot of the time. It actually sometimes stresses and worries patients out a bit more, and also confuses their clinicians when they go for scans unnecessarily. Because often what we see on scans sometimes are incidental findings, sometimes they're age-related findings, and then sometimes we misinterpret that as the cause or the source of their symptoms when they've been pre-existing for years and years and years without causing them any symptoms. So, you know, if you're over a certain age, you're going to start to see changes in your spine. You know, it's just a natural aging process. But we used to think that these natural aging changes were pathologies, were things that cause pain and problems. So, you know, facet joint arthropathy, disc degeneration, you know, even disc prolapses, you know, all these things that were thought to cause people pain and disability have been seen in numerous studies in people without any pain or disability. So researchers has started looking with imaging, not just at people with problems, but also the healthy population as well, the people without pain and disability. And when they go in for scans, we're amazed, we're surprised at the amount of things that these individuals without any symptoms at all have appearing on their scans. And that confuses us now, because now we've got people who have got disc prolapses, who've got arthritis to their spine, who've got signs of muscle and tendon type of issues and pathologies in their back, yet they're reporting zero pain and disability. You know, and I've seen some scans in some asymptomatic populations that make my jaw hit the floor. I'm like, how the hell are you still being able to walk around with a grade 5 spondylolisthesis that you'd think would be absolutely disabling somebody? And they're like, no, perfectly fine, no pain at all. And I see that in all parts of the body, not just the back. I see it in the hip joints. I see it in the knee joints. I see it in the shoulder a lot as well. Pain-free individuals with, say, so-called pathology in their joints. And so, you know, we've got these studies that tells us there's more complexity to just looking at a scan and saying, aha, there's where your problem lies. That's what your issue is. Because it just isn't that simple. As I say, there are lots of other reasons as to why people have pain. And so if they go for a scan and we see these signs of life and age related changes, and we think they're the cause of their pain, and we start treating them, it may not improve their symptoms, it can actually make them worse.
Yep.
So a lot of the time I say to patients, the only reason for going for imaging or scan is if we suspect there's something in there that needs a different approach, if there's something in there that needs a specific type of treatment. And normally, you know, if we're sending for people scans, it's because we've got some signs or symptoms that's leading us to believe they've got something a bit more specific or a bit more serious that could be contributing to their symptoms. That's the only people that I would refer for scans for back pain. So if they had these red flag signs and symptoms or signs of specific pathology that needs other interventions other than just watchful waiting, natural history effects, and physiotherapy type treatments, then I would recommend they get scans and images. But otherwise, I try to reassure people most of the time they don't need it, which isn't always easy to do and not always done. So I wish I had, again, a magic secret that I could tell people how to reassure people that they don't need scans, but I haven't got that.
Yeah, unfortunately, I think that takes a lot of education. You know, it would be great if you could give everybody a physiotherapy degree, but even that doesn't solve the issue for a lot of people. On that note,
I think I'm trying to convince the physios a lot of the time not to do it is even harder than trying not to convince the patients to do it.
Yeah. On that note, I suspect if we did scan everyone, it would do a lot more harm than good. And I suspect if we scanned everybody with, you know, what you would class as non-specific low back pain and tried to give them a diagnosis, we would not actually be able to. I would imagine more often than not, the scan would come back perfectly normal, or the scan would be identical to a scan they had before they had back pain.
Yeah. One of my favorite papers here, for highlighting this effect beautifully, was a paper done by Herzog. I can't remember the year, but I think it was around 2010. So it was about a decade or so ago. They had one individual with non-specific low back pain go and have 10 MRIs in 10 different units over 10 different days. So they were asking this individual, say, same person, to go into different MRI units to have an MRI for their back pain. And there was 10 different radiologists reviewing this scan, and they had to report back what they found. So the same individual, there was over 49 different pathologies reported for this one episode of acute back pain. And none of the radiologists agreed on one pathology as the source of their back pain. So over 49 different diagnoses were given, but none of the radiologists agreed on the same diagnosis as the cause of the back pain. So that just goes to show there's a lot of misinterpretation and sometimes, I say, misunderstanding on MRI scans. Yeah.
And it just goes to show the cost of getting an unnecessary scan, because let's say that person was having treatment for any of those pathologies. Imagine just firstly the time and cost wasted scanning the person, and then the treatment after that. So I think this is very relevant to the calisthenics population, because you often see these incidental findings on scans in athletic populations. Throwers have terrible shoulders on an MRI, but they have very, very functional shoulders in everyday life. And that's asymptomatic throwers. So generally, if I have an injury, and this is somebody who has access to great healthcare, I have a good relationship with physios, surgeons that I could go to, can go get an MRI, and I would often opt not to, because I think a lot of the time you would find something incidental, which can have a really bad effect on your psychology. And it can lead to you treating something that doesn't need to be treated. So to give a few examples, I had a groin MRI when I ruptured my adductor tendon, and it showed a cam lesion on the other hip. I don't have any hip problems, and a ligamentum teres tear. And you know, if I was just treating an MRI, just treating radiological findings, I would go and get surgery, spend a lot of money, probably have a hip that has undergone trauma that is unnecessary for absolutely nothing. So there's some advice as both a physio and an athlete for anyone listening.
Yeah, no, I agree. I think, as you say, depending on the type of sport, hobby you do, the level that you do it at, you're going to expect to see, different things in those scans compared to the general population. And again, the athletic population, they do get routinely screened and imaged for, insurance purposes if they're in professional sports. And having worked in those situations before, I've seen the negative consequences that have on professional athletes going for these insurance scans and then reading the reports or being informed of the reports and being told that their body's in a shit show. And these poor young individuals performing at really high levels, it can have a negative effect on their feelings of robustness and resilience. It can actually make them feel fragile and delicate. And that's the exact opposite of what we should be trying to do for athletes. So yeah, I do agree. I think sometimes, you say, with all intentions, these imaging reports and the way it's fed back to people actually makes them feel delicate and damaged and fragile, when actually it's showing signs of adaptation and robustness and resilience. I'm like, fucking good. You got a thickened ligament on there. You got a great big old strong bit of muscle there that other populations haven't got. That's how imaging should be reported back. I've seen some scans of some professional athletes, and you look at their muscle girths, you look at the quality of their muscle fibers, their fatty infiltration, the multifidus, basically zero. Yet all they've been told about, oh, you got a thin disc. Like, forget that thin disc. Look how fucking juicy and thick your multifidus muscles are compared to the general population. Look at that. That's all that exercise you're doing. You don't need to worry about that thin disc. Fuck that. But nobody reports images back positively. It's always finding the negatives. It's always, this is bad, this is bad, this is bad. Switch it around. What's good? What's good? What's good? Where's the good bits in the scans? Because there is good stuff in scans that you can use it positively, not just negatively.
Yeah, absolutely. Yeah, and if you treated every incidental finding, take the knee, for example, everyone that has a meniscus tear, you go and perform a meniscectomy or a partial meniscectomy, and you basically assure that person has arthritis in the long term. So I think often it's better not to treat something aggressively and to be conservative if you can. And that's where having a good versus a bad health professional can really make a huge difference. So on that note,
Absolutely.
if I've got back pain, let's say I come to you, I'm going through an episode of back pain. What's the best exercise? What should I do?
Whatever you enjoy doing that you feel like you can do at an intensity that doesn't really aggravate or provoke your back pain. For me, that's where I am at the moment. So I think, it's finding something that fits with a person's levels of irritability, sensitivity, disability with their episode of back pain, which is hugely different from person to person. Some people with back pain can do some really high level things without it flaring or irritating things up. Other people are struggling to get out of bed in the morning with agony and pain and discomfort. So I think it's having that adaptability and flexibility, being able to say to people, well, you're at this level at the moment, lots of irritability, lots of disability. So let's find something that you enjoy doing, that you can do, that doesn't flare it up too much. And that may be something as simple as a few floor-based exercises, maybe a few of those cat camels, maybe a little bit of knee rolling, maybe going for a little gentle walk for a couple of 100 steps. And that's it. And that's as much as your back can tolerate for that particular time. Good. That's okay. But then there's others that can do, long lever planks, and they can do, reverse hyperextensions with half their body weight still on, and stuff like that before their back starts to feel uncomfortable. And they can tolerate that and say, great, if you enjoy doing that and that's what you want to get back to and it hasn't flared it up, crack on with those type of exercises. So I don't think, as you say, the simple answer is there's no one magical exercise for back pain. It needs to be an individualized approach based on the person's pain and irritability and disability with their back pain. I treat people's problems, not their pathologies now. That's something I've changed over a while. It's not feeling that I have to treat their diagnosis. It's treating the person's disability and their problems. So that's very much a switching change of clinical reasoning for me now. So, I'm still keeping an eye out for pathologies. Like I said, I'm not completely nihilist. I don't just say, oh, pathology doesn't matter, because it does sometimes. But, a lot of the time when I've got a lot of uncertainty about the pathology, I know, well, it doesn't really matter because they all respond similarly to the same types of approaches, to the same types of treatments. So therefore, we can now start to treat the person and their problems rather than stress about the pathology.
And I know you're a big advocate of strength training. So I'm going to throw a curveball question at you. Do you think people with back pain must do some strengthening? Is a lack of strength contributing, and is getting strong important in somebody's recovery?
You have thrown a curveball at me, Simon. It's a great question. And my biases are screaming at me inside my head to say, yes, 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 get everybody doing strength training. I think the first thing I'm going to say is I've actually changed the term of strength training to resistance training now. So I actually think resistance-based training, okay, is a better way of framing it rather than calling it strength training, because I don't think people have to get stronger, okay, because I see a lot of strong people with pains and problems. So, I don't think they need to get stronger, but resistance-based training, using things under load, under resistance, I do find a simple and effective way to help people with pains and disability and problems a lot of the time. But it's not every time. It's like anything. There is no panacea. There is no magical cure type of exercise. But I do think it works for a lot of the people.
Does that include tib ant raisers? I just want to get you on record.
Yeah, well, I don't think they're going to do much for back pain. That's a good point as well. The specificity needed for an exercise to help somebody. So I've had these discussions a lot of the time, and I've had some people that are quite a way far down the spectrum of where I am with non-specificity. Now, I don't think I'm the most specific type of practitioner. I don't think you need to be focusing on your multifidus muscle. I don't think you need to be focusing on your transab. But then there are some clinicians who say, oh, you could give calf raises for people with back pain, and it probably be just as effective as giving, lower back hip hinges and stuff like that. And I'm like, really? Can we be that non-specific? Can I just give calf raises and it will still help people with back pain? And there are some people that says that. I haven't quite got down that pathway yet. I still think we need to keep it local to the area. I still think you need to do some sort of exercise around the back lumbopelvic area to help people with back pain. Likewise, somebody with knee pain, we need to keep it around the knee joint area. Giving people shoulder exercises, rotator cuff work for their knee pain is probably not going to make much difference, probably. But again, there's probably still some uncertainty there that may say they could do. So I think there needs to be an element of specificity. It just doesn't need to be as specific as it first thought.
So I wanted to talk to you a little bit about spinal flexion in the deadlift. So when I went through, just to set the background, when I went through university, we were told to avoid spinal flexion, bend from the knees, keep a neutral spine when you lift anything, or you could injure your back. And this was never really based on anything too sound. And I think as more and more evidence has come out, a lot of people, especially on social media, have swung the other way. And they've said spinal flexion almost certainly occurs in the deadlift. Manual handling to avoid spinal flexion doesn't seem to work. And some people seem to say spinal flexion doesn't matter. Could you give a little bit of your stance on that, and then we'll get into some more specific questions?
Yeah, good question. And I think, again, it's trying to find the middle ground here is where I think the best place to be, like most things are, is found. So I agree, you know, the myths of having to avoid all spinal flexion under load or any resistance or any stress has been pretty much disproven. One, you can't do it, and two, I don't think it's necessary to do for getting backs and structures strong and robust and resilient. But I also don't think the research tells us that it means that anybody can do all types of flexion with all types of load and all types of resistance and be perfectly okay and safe with that either, because I don't believe that's the case either. So again, I think it's all about the parameters of the individual, the intensity, the exposure, and the load of that spinal flexion. So I think max effort, end of range spinal flexion in some individuals, in fact, in probably a lot of individuals, particularly the novices, is a high risk strategy, like it would be for putting any joint or any body part under high intense loads at end of range. You know, if you're to bend your little finger back into a position and hold it there at high intensity and high loads, I've got a high suspicion your little finger joint might start complaining and getting stressed and sensitized and irritated. And I think it would do the same thing in your back as well. I think, you know, it's the extreme.
Sorry to cut you off. I really like that you said that, because I fully agree that injury risk does have something to do with the load lifted and the proximity to end range. And an absence of evidence doesn't necessarily mean an evidence of absence, or it doesn't at all mean an evidence of absence. So if you just took the parallel to say, look, we don't have any evidence to suggest, or we don't have robust evidence to suggest that spinal flexion under load is dangerous and injurious for your back. I could say, agreed, but that doesn't mean I'm going to let everyone just deadlift their one arms with a question mark spine. And you could take the analogy of the elbow. I don't think we have any robust evidence to suggest that elbow extension under load is injurious for the elbow. However, an arm bar in jiu-jitsu is reliably used to break people's elbows. And even though we don't have an RCT to support it, it makes perfect sense that you would want to avoid end range extension under heavy loads.
Yep.
So,
but there is some research that sort of supports that. Look, when we look into powerlifters and strongman athletes, we do see a lot of spinal flexion occurring when they do these lifts. But what we don't see is them using their max available range of flexion.
Yeah.
So they use anywhere between 70 to 80% of their max available end of range. So it looks like they're avoiding that last 20 to 30% of end of range spinal flexion when these very strong, very powerful guys are doing these extreme intensity lifts. So, you know, if we can extrapolate from that sort of data, it allows us to say that if these individuals are getting spinal flexion, but they're just not going into end of ranges, that probably allows us to say we should be doing the same thing for most other people as well.
I imagine you're not a very Q heavy coach, you know, neutral spine and like you see a lot on social media. If you did see somebody deadlifting with a great deal of spinal flexion, is that something you would correct? And what would your justification be for that if so?
Yeah, so the tricky bit I've come across here is trying to work out when somebody is at their maximal end range of flexion, which is that risky area, you know. So just from observation alone, it's very hard to determine that, because we know, say, our ability to observe spinal kinematics is nigh on not there. You know, you need very specialist equipment to be able to measure accurately lumbar pelvic movements during these types of exercises. So the first thing I have to say is that although it may look they're at their end of max flexion, they may not be, although it looks like they've got this question mark deformity going on. they've still got another 20 or 30% left to go, which means they're still technically in these safer zones. But, for me, when I'm coaching somebody doing an exercise, I use what I call the vomit test. So if there is an exercise being done that makes me want to vomit or dry heave, it looks something like just ugly, then I tend to ask the individual to stop. And then the first thing I'll do is I'll ask for their internal feedback. So I think when we're coaching exercise, we've got to use both internal feedback from the person doing the exercise based as well on our external observable feedback of what we can see. So I've seen something that makes me want to vomit. I'm like, that doesn't look good. That just looks horrible, looks inefficient, looks like it could be injurious. But then I'll go and ask the person and say, how did that feel to you? Now, if they turn around and say, you know what, that just didn't feel good. I didn't enjoy it. Didn't feel like it was performing well. Felt a bit uncomfortable. I like good because it looked like that as well. Okay. So we've got external, internal feedback now meeting together saying, doesn't look good, doesn't feel good. Let's try and do it a different way. Let's give some strategies. Let's coach it slightly different and see if we can find that internal feedback go up and my external observable feedback also improve as well. The problem I have is occasionally when I see something that's a positive vomit test, I'm like, oh my God, that just looks awful. And then I ask the individual, how did that feel to you? And they go, it's great. That felt wonderful. It's felt the best it ever has done. I'm like, oh, damn it. Now I've got a little bit of conflict here and I'm like, what do I do? Do I trust my external feedback or do I trust that person's internal feedback? What's the better approach to take here? And for me, I don't think there's a right or wrong answer, but for me, I would trust the individual's internal feedback over my external feedback. So I'm still sitting there dry heaving, looking at this deadlift going, this just doesn't look right. This looks horrible. But the person's loving it. They're enjoying it. Go, this is great. This is the best I've felt doing these exercises for the last 3 years. I'm like, okay, all right. Well, if you've got that positive internal feedback and they're happy, just because I don't like the look of it, I'm going to let it carry on. But I don't like it. Makes me feel uncomfortable. And I've seen other people in the gyms and coaches looking at me going, why is this guy letting this person do that exercise really, really badly? So it makes me feel awkward when I let clients do it. But I've realized a lot of the time internal feedback overrides my external feedback. So I'm much more likely to say, let somebody do something that looks a little bit ugly and horrible if it feels okay for them. There are some individuals, though, that are novices at it. And although they're saying it's good, they haven't tried other ways of doing it. So again, if I'll say to them, okay, well, I'm glad it feels good for you doing this way, but just try this one way that I'd prefer you to do it and see if it feels even better. So I still think sometimes it's good to experiment and give a novice who hasn't had a go at using different variations of different types of exercises an exposure to different ones to see, again, although it did feel good, does the next variation that looks better feel even better than that other one? So I still would do that as well for the novice. But for an experienced lifter, yeah, I trust their internal feedback a lot more than my observable feedback.
Yep. I see no problem in cueing a neutral spine or cueing the intention of a neutral spine. However, the rationale that you give for why you want to avoid spinal flexion does matter. And if you're saying, cue a neutral spine because it's a great way to develop spinal control, maybe you want to have some transferability to a vertical jump where you want to keep a rigid spine, that's great. But if you're saying keep your spine neutral because flexing your back is going to make it explode, that's where there's a bit of an issue. Can I get your feedback on that?
Yeah, no, I absolutely agree. I think, developing tension at certain times, in certain positions, in certain movements is a really useful strategy for people to be able to do. So keeping things stiff and rigid, under load, under intensity, absolutely great. So again, I don't think there's anything wrong with getting people exposed to that and used to that. And that's something that occurs in a deadlift. Keep your spine tense, keep your spine stiff and rigid, as you do the picking up the heavy load. So I think, there's nothing wrong with that at all. I think, again, it's just recognizing, as you said, it's not being done for the reasons we thought it was being done for. Being in a neutral position isn't some magical, mythical place where injuries never occur, which is what a lot of people think. The reason I'm coaching this is to keep them in neutral, which is this less injurious area. And that's just not true at all. So we see injuries occurring in all sorts of positions and angles as well. So again, just having that understanding and that rational approach to exercise, I think, is a good place to be. It's having adaptability and variety and variability. If you're aligned to saying everybody's got to do it under flexion or everybody's got to do it in spinal neutral, you're going to be wrong 50% of the time. But if you're quite happy to go into both areas, you're going to be a much more better coach. You're going to be able to personalize and individualize your exercises to the person and the individual in front of you. So I think that's a good place to be.
Yeah, I think that's great, and it's something that a lot of novices should understand, is that a lot of things are very highly individual. So what can be injurious to one person can be perfectly safe and promote resilience for somebody else. And there's rarely in health and fitness are there black and white answers. You shouldn't do this or you should do that. You should never pull up with your head in front of the bar. You know, I don't recommend it for most people, but it's absolutely fine. I don't think it needs to be avoided as an absolute.
Yep, no, I agree. But again, it's one of those things that tends to occur on social media nowadays. It's very tribal. It's very dichotomous. It's either them or us. And again, that finding the middle ground, keeping balance, having nuance, just often gets lost on social media. But as long as you're trying to work your way through it, I don't think you're going to go far wrong. Yeah,
nuance isn't sexy, and it's also difficult to provide a public health message with nuance. So it's
absolutely
it's a challenging problem to solve. I realize I've stolen over an hour of your time, Adam. So thank you very much for providing all of your insight.
No worries, Simon. Thanks for the invite. Enjoyed it.
Would you be able to let people know where they can find you and find your resources?
Yeah, sure. So obviously I'm on social medias like most people. So I'm on Twitter at Adam Meakins. I'm on Facebook as the Sports Physio, and I'm on Instagram as Adam Meakins as well. But I think you can find me easily either under the Sports Physio or Adam Meakins on most social media platforms. I've got a website as well, which is the sports.physio. It's one of these strange ones. It's not a .com, it's a .physio account. And I post some blogs and stuff and up there, and the schedule of courses and teaching that I do as well there, which people can go and check out if they want to.
Great. You have a few courses and lectures on there. Do you want to just...
Yep. So I've focused now for the last 10 years into the management of the upper limb. So I would class myself as a shoulder guy, although I still see people with back and knee problems. But I do a course that tries to simplify the shoulder, but not make it dumber. Not because that's what I think a lot of people think this realistic evidence-based approach tends to be. It's just dumbing things down. I'm like, that's not the case at all. Simplification isn't dumbing things down. So it's called the painful shoulder. Complex doesn't need to be complicated. It's a 2-day course to say looking into the painful shoulder, and the principles that I use in the painful shoulder for simplification in approaches to assessment and management can also be transferred into other body areas as well. But it's just based around the painful shoulder.
Yeah, and I'm going to plug your manual therapy myths seminar as well, because I think that's great. I think a lot of people have this idea when they see a physiotherapist that they can magically feel things. And I encourage you to be very skeptical of that if you do see a physiotherapist. And if you'd like to learn more about that, definitely check out the manual therapy myths video. Thanks very much, Adam, and hopefully we can do it again sometime.
Appreciate the chat, mate. Take care.